Today we'll be talking about some newborn complications. This information is taken from the ATI book, chapter 27. Fetal growth is influenced by so many things. These are just a few of those things on the slide. And this is one of the reasons that on the clinical unit, we want you to look at the mother's chart to see if you can identify anything in the mother's history that may have affected that growing fetus. The first complication of the newborn that I want to discuss is neonatal abstinence syndrome. And this comes from the fetus being exposed to substances while it's growing inside the uterus. The baby's exposed to pretty much everything that the mom ingests. So for all intents and purposes for this course, we'll be primarily discussing neonatal abstinence from opioids. But I want you also to be aware of that babies can withdraw from other substances, whether they're legal or illegal, prescribed or recreational. For example, some women are prescribed opioids if they have chronic pain or if they have acute pain. These babies are at risk for developing neonatal abstinence syndrome, even though that mom is taking an opioid that's prescribed for her. Some women take antidepressants, SSRIs, for a clinical depression, and babies can withdraw from medications like Zoloft. Think too about the over-the-counter substances that many women ingest during pregnancy, like caffeine. So caffeine should be limited in pregnancy. However, some women are addicted to or enjoy a cup of coffee, a cup of tea, a Mountain Dew, a Pepsi, or a cola. As soon as the umbilical cord is cut, the baby isn't exposed to that substance anymore. Think about how you feel when you don't get your morning cup of coffee or morning Mountain Dew. So just something to consider. Another readily available substance that babies can be exposed to is nicotine. So if you know someone who uses nicotine products, you probably know that they experience withdrawal if they would try to quit. So I give those examples to let you know that we need to be non-judgmental when we deal with all of our clients, but especially those that have substance use disorders. And again, I'm primarily going to discuss neonatal abstinence syndrome through the lens of opioid use. These moms that take opioids, they feel that we are judging them, and we really need to enter that relationship with our patient in a non-judgmental manner so that we develop a trusting relationship and a good rapport so that we can provide the best care to that patient and their baby. I also want you to think about medication-assisted treatment for substance use disorders. There are many programs in many communities that help patients that have a substance use disorder, primarily opioids. These programs help these clients with their substance use disorder. So when clients are on methadone or Subutex or Suboxone, that's a prescribed treatment and it is not an illegal substance. So we do really need to approach these individuals in a non-judgmental way in order to keep those lines of communication open. All right, on the left-hand side of the screen, you'll notice that there are some labs that we will want to collect for these patients. Now that first urine tox screen, many pregnancy clinics collect a urine tox screen on all of their patients at the first with their prenatal blood work, just to do a screening to see what's going on. That way we can be planning for a length of time for that baby and neonatal abstinence syndrome. If a woman has illegal substances in their urine, we can also provide referrals so that the woman can provide a better environment for her fetus to develop. A urine drug screen is usually done on the mom when she comes into the labor room, but not always. Usually if a mom has a positive tox screen at some point during their pregnancy, this will be like a standing order. After the baby's born, if the mom has a history, the pediatrician usually orders a urine drug screen for the baby, may order a meconium drug screen, may take a little section of the cord to send it away to test for substances. And other labs that I don't see very often would be a CBC for neonatal abstinence and a blood sugar. And we'll talk about hypoglycemia and blood sugars in just a short time. Nursing management, we want to do ongoing assessments to assess for symptoms of withdrawal. We want to promote comfort and reduce stimuli. So in the coming slides, you'll see some of the expected assessment findings, but these kids are usually hyperstimulated. Their CNS is very irritable. So we want to make sure that the lights are dim. We want to provide a quiet environment so that we're not stimulating an already hyperstimulated CNS. We want to provide nutrition to these babies. A lot of these babies have tremors, so they're using a lot of energy with their tremors, and also they're typically poor feeders. They lack the coordination of the suck, swallow, and breathe. So they like to suck on a pacifier that provides comfort to them, but when you add like a liquid through a nipple, they just don't know what to do with that liquid, and they'll chew on the nipple, and the milk or the formula will just run down the sides of their face. They will gag, they will sputter, they will regurge. Nutrition is a problem with these kids. We want to prevent complications like seizures, excessive weight loss, skin excoriation. We want to monitor parent-newborn interaction and bonding, and we also want to provide good role modeling for these families with substance use. Not to be judgmental, but and I'm trying not to overgeneralize, but some of these families haven't had good role modeling in parenting. So we need to provide that role modeling for that short period of time when they're in the hospital right after their baby's born. And then finally, if babies require medication for their neonatal abstinence syndrome, we would administer those medications. So on the left-hand side of the screen is the typical appearance of a baby with fetal alcohol syndrome. In my years in nursing for maternal child health, I don't recall ever seeing a baby born with fetal alcohol syndrome, but we know that it's still out there. I am not going to focus that on for the purposes of this course or for testing purposes. I will focus on opioids. So I started to talk about that CNS irritability, tremors, high-pitched cry. You'll probably see tachypnea, sneezing, nasal stuffiness. Think about what you know about like heroin users that are starting to withdraw. These babies also go through these same symptoms. So vasomotor, they may be sweaty, they're tremoring, so they're increased body heat, hyperthermia, they might be sweating, they might be, their skin might be mottled, they're shunting their blood to the core for whatever reason. We're going to have feeding difficulties, as I mentioned. mentioned regurg or vomiting, diarrhea, and then excessive sucking. Like I said, they want to suck on the pacifier for comfort, but when you add that liquid, then it's they just don't know how to handle it. So moving on to hypoglycemia, first of all, I want you to take note of what a normal newborn glucose is, and that's greater than 45 milligrams per deciliter. When we take a blood sugar for the newborn, we're going to be doing a heel stick and then testing it with our glucometer on the unit. So on the left-hand side of this slide, you can see some risk factors: maternal diabetes, whether it's gestational or pre-gestational, meaning that the woman had it before she got pregnant. That is a big risk factor. And I don't know whether you know this, but you'll learn this in level 3. Diabetes is when the pancreas isn't making enough or any insulin. And insulin is that hormone that is required to move the glucose into the cell so the cell can use the glucose for energy. So with a patient that has diabetes, a lot of times their glucose is elevated because they don't have enough insulin to move the glucose into the cell, so it stays in their blood. So how does that affect the newborn? Well, glucose is a very small molecule, and small molecules like glucose easily cross the placenta. So whatever the mommy's blood sugar is, the baby's blood sugar is going to be about the same. Now think about insulin. Insulin is a big molecule, and the mom either doesn't have any insulin to be able to, move into the baby, but it's not going to move anyway because it's such a big molecule and it won't cross the placenta. So babies don't have diabetes. They have healthy pancreases, so they're going to be making lots and lots of insulin in order to use all of this glucose that they have. And when they use all this glucose, they are putting it down as subcutaneous fat. So these kids that are born to moms whose diabetes isn't controlled in pregnancy, they're usually large for gestational age. So when the baby is born to these moms that are uncontrolled, that have these high glucoses, the baby has the high glucose and makes all this insulin, and as soon as the baby's born and the cord is clamped and cut, the baby doesn't receive any more glucose from the mom. But the pancreas isn't just going to stop producing insulin. It's going to keep producing insulin. So it's going to burn through whatever that glucose is fairly quickly. And that's why we have to keep an eye on these kids when the mom has diabetes. Preterm babies we have to keep an eye on because they have more stress and they have less subcutaneous fat. Same with the small for gestational age. We talked about the large for gestational age babies because it's probably related to higher glucose levels and they're producing more insulin. And then we also have to pay attention to those babies that have undergone some stressors. For example, if a baby has some fetal distress and needs some resuscitation at delivery. So some of the assessment findings that you'll see when a baby has hypoglycemia are jitters. They're a little bit jittery. They might have some hypothermia. They might be cold. If you don't have as much glucose circulating, you're not going to have a lot of energy. So these babies could have poor tone and be lethargic, and they're going to be poor feeders because they just don't have the energy, the glucose in their system to be able to make their muscles move like that. Nursing interventions for hypoglycemia, typically in the hospital, there is a set of standing orders that's the pediatrician or the neonatologist will order for those babies at risk, and we'll will get a heel stick. If it's low, if the glucose is low, again, there are standing orders. We'll want to provide nourishment, either breast milk, colostrum, or formula, depending on the mother or the family's desires. And in extreme cases, when the blood sugar is extremely low or not responsive to any other treatment, babies might have to be transferred into the NICU for IV D10 and W. So of course we'd want to treat the underlying cause. Sometimes hypothermia can lead to hypoglycemia, so we'd want to make sure we rewarm the baby and then remove any other stressors. Moving on to respiratory disorders of the newborn, I want you to take a good look at the risk factors on the left-hand side. Preterm gestation is probably the biggest risk factor because they don't have as much surfactant. And we talked a couple of weeks ago when we talked about the newborn how surfactant works. Surfactant lowers the surface tension of fluids, and it makes it easier for the baby to take their first breath. So the longer the gestation for the baby, the more surfactant is in the lungs. Preterm babies have less surfactant than term babies, so they may have some respiratory distress at birth or shortly thereafter because of the lack of surfactant. Babies that undergo or have asphyxia at birth, whether it's due to meconium or some kind of a cord compression, cord accident, may end up with the respiratory distress. Meconium is the baby's first stool, and if the baby were to aspirate some of the fluid that has meconium in it, it can lead to respiratory disorders because meconium kind of uses up some of that surfactant. Mothers that have diabetes, this usually causes a little bit of a delay in surfactant development in the newborn, so those early term kids may have more respiratory disorders, respiratory distress than babies born from moms without diabetes. Premature rupture of membranes. A C-section can also put this baby at higher risk for respiratory disorders. A normal vaginal delivery, the baby is passed through and squeezed by the birth canal. With a cesarean delivery, the baby isn't squeezed like that, so it may take a little bit longer to reabsorb and to open those airways up. You can read through those assessment findings. Tachypnea, we talked about flaring, grunting, and retractions in the newborn lecture. You may hear some crackles in the lungs, as well as cyanosis and poor muscle tone. If this kiddo is working to breathe, it's going to put its energy into working to breathe and not into other muscle tone. Next, we'll talk about the preterm newborn. Preterm newborns could be born before they're due at 37 weeks for a variety of reasons. These risk factors are listed on the left-hand side of the slide. Providers may opt to deliver women early if they have some kind of a pregnancy complication or a medical complication that puts either the mother or the fetus at greater risk than delivery. On the right-hand side of the screen, you'll see a whole list of potential complications from preterm deliveries. So that top one is respiratory distress syndrome, and we talked about respiratory distress earlier on another slide. The next one is bronchopulmonary dysplasia, and that just means that the respiratory system didn't have a chance to fully develop because of the prematurity. These babies are at risk for aspiration because they have trouble coordinating their suck, swallow, and their breathe when they feed. They're at risk for apnea, usually in that goes along with bradycardia. So these preterm newborns are often on cardiopulmonary monitoring in a NICU. The next bullet point is IVH, which is intraventricular hemorrhage, and that's inside the brain. Babies that are born prematurely have a higher risk for this complication. The next one is retinopathy of prematurity. Babies that are born early, the vessels in their brain and in their eyes are not as mature, and they're very, very fragile. So this puts them at risk not only for that intraventricular hemorrhage, but also for that retinopathy of prematurity. The next one is patent ductus arteriosus, or PDA. And a few lectures back, we talked about the differences in fetal and extrauterine circulation. Some babies, it takes them a little bit longer to close that ductus arteriosus. The next one is NEC, or necrotizing enterocolitis, and we have a couple of slides coming up later in this slide deck. Preterm newborns, their assessment findings, you're going to see low birth weight, LBW, because they haven't had time to put that subcutaneous fat down. They haven't been in the uterus as long. Sometimes babies that are born before 24 weeks, you'll see their eyelids fused, and that's normal. Their eyelids usually don't open until they're at least 24 weeks gestation. Back in the old days of maternal child nursing, before we had so many technological advantages as we do today, it was a rarity that we would resuscitate a baby who was less than 24 weeks gestation. And we would make that determination by looking at whether their eyelids were fused. Nowadays, some babies are resuscitated at 22 weeks and a few days and are surviving, but these babies usually have lifelong complications. These pretermers also have poor muscle tone, they're poor feeders, they don't have the maturity. And I mentioned apnea in that previous slide. The most important thing, the priority nursing care, is to stabilize. So remember your ABCs, airway, breathing, and circulation. We also want to support thermoregulation. Oftentimes these preterm babies are placed in an isolette, and it's a warm environment for them. We don't want them to have to put any energy into regulating their temperature. So that's called a neutral thermal environment. Next, we'd provide respiratory support, and we could do that with ventilation, ventilator, or continuous positive airway pressure, CPAP. We'd want to support their nutrition. Now, these kiddos that are receiving respiratory support, they probably will be NPO, but these babies are poor feeders. Once they are able to take nutrition orally, they're usually unable to, and you'll see nasogastric tube feedings or orogastric tube feedings in order for them to receive nutrition. In some circumstances, total parenteral nutrition through a central line is required. The next bullet point on this slide is developmental care. And if you think about it, these babies should be inside their mommies for 37 to 42 weeks. But yet some babies are born prematurely. Many NICUs practice developmental care, and this developmental care has to do with keeping the environment as close to being inside the uterus as possible. So low stimulation environment, low lighting, low noise, and they cluster their care. They do the vital signs, the diaper changes, the assessments, the feedings, the medication administration, all at once, and then they allow long periods of rest in between. Developmental care also has to do with positioning. So inside the mom's uterus, the baby would be all flexed in the fetal position, and that aids in musculoskeletal development. So we would want to also make sure that we reposition the baby in that flexed posture, and we would also want to make sure that we don't cause pressure ulcers. So we'd want to turn them from side to side, let them lay on their abdomens and on their backs so that we don't cause pressure injuries. Of course, we'd want to prevent infection, and that's good hand hygiene as well as keeping sick visitors away from the bed space. I&O, we need to do meticulous I&O on these little tiny babies. They're quite vulnerable. So we measure output by weighing diapers. We even use output as if there's a blood draw, we're going to count that 1 milliliter of blood as their output. And we're going to pay very close attention to their oral and their IV intake. So if you remember from a previous lecture, SGA, small for gestational newborns, are those newborns that are in the less than the 10th percentile for birth weight. And I hope you remember seeing that graph that's in your clinical packet. These babies, their risk factors include those items listed on the left-hand side of the slide. And these kiddos are at risk for asphyxia, meconium aspiration. We talked a little bit about that earlier in this slide deck. So these babies, because they're small, they may have a risk for meconium aspiration, so they pass some stool inside the uterus and then they aspirate that. These kids are also at risk for hypoglycemia. They don't have a lot of birth weight. They don't have a lot of subcutaneous fat for energy production. They may have polycythemia, too many red blood cells, which would then lead to hyperbilirubinemia, and we'll talk about that more later in the slide deck. And then hypothermia. And we talked about hypothermia with the normal newborn and all the mechanisms that keep those babies warm enough. These babies don't have a lot of subcutaneous fat. It's an insulating layer. And if you add into that prematurity, those babies also have very thin skin. So these SGA babies have quite a lot of risk, or they're at risk for a lot of stuff. And as nurses, we have to be aware of these things and then try to prevent them and treat them as they come up. This is just a slide for your information, different characteristics of that small for gestational age newborn. Their heads look disproportionately large. They might look like wasted appearance, like loose, dry skin. I already mentioned the reduced subcutaneous fat stores, decreased breast tissue, thin umbilical cord, poor muscle tone. They're all characteristics. And if you see on the right-hand side of this slide, there are several different pictures of different body parts that give you a good indication of those SGA characteristics. So this is another really just nice feel-good slide. This is a mom who's doing kangaroo care with her twin babies. And again, with these SGA babies, we want to support their ABCs, respirations. We want to prevent hypothermia, support their nutrition and hydration. And definitely this slide shows about bonding. So we definitely, once their physical needs are stable, we definitely want to promote bonding. On the other end of the spectrum are the large for gestational age newborns. And thinking back to that graph again, these babies plot out above that top line over the 90th percentile. You can read through the risk factors on the left-hand side of the screen, and these kids are at risk for birth trauma. So they're bigger babies, and yet they have to fit out the same size birth canal. So there could be some risk for birth trauma, maybe a fractured clavicle or a brachial plexus injury. That's a nerve plexus that's in the neck. They're also at risk for cesarean delivery. Some babies that are really big, they just don't fit out. Asphyxia, hypoglycemia. Remember when we talked about hypoglycemia earlier in the slide presentation? Big babies, their mothers might have had an uncontrolled high blood sugar. So we have to pay particular attention to whether these babies develop hypoglycemia. And these babies too are at risk for polycythemia that may lead to hyperbilirubinemia, which we'll talk about in a little bit. So these kids look large, they're plumped, full face. They have a proportional increase in body size. I mentioned birth trauma. They may have poor motor skills, again, hypoglycemia, and may be predisposed to respiratory distress syndrome. We want to monitor their vital signs, monitor their blood glucose levels, and we do want to initiate oral feedings as early as possible. Some of those hypoglycemia protocols include PO glucose supplementation as needed, and for those extreme cases, IV glucose supplementation. And we'll talk about phototherapy as we talk about hyperbilirubinemia. For post-term babies, remember again that a term baby is anywhere from 37 completed weeks to 42 completed weeks. After 42 weeks of gestation, these babies are called post-term. And when we think about all of the physiology of pregnancy, remember that the baby is attached to the umbilical cord that's attached to the placenta. And the placenta developed from the products of conception. So, and after the pregnancy, that placenta is expelled. So this is a deciduous organ, and it does age. It's not meant to be around for 42 weeks and longer. So it gets less and less efficient as the pregnancy progresses. So these babies are at risk for cesarean birth because we might see some non-reassuring fetal heart rate tracings, like late decelerations that indicate placental insufficiency. That may lead to meconium passage inside the uterus and then meconium aspiration. Asphyxia just means the baby is not getting enough oxygen. And then because these kids, the placenta isn't working as well, these kids could actually lose weight in utero over the last few days or weeks of pregnancy. And that may lead to less subcutaneous fat that may lead to hypothermia, hypoglycemia. And these kids are also at risk for polycythemia and hyperbilirubinemia. Typically these kids, they don't have any vernix or very little vernix, no lanugo. They're going to have cracked, dry, wrinkled skin, long nails. They're going to be more alert because they're more mature. And they may look wasted because they've lost weight inside the uterus. We already talked about meconium staining, and that's due to the passage of that first stool inside the uterus. And believe it or not, some of these kids can have macrosomia or be large for gestational age. So primarily we want to look at the priorities being airway, breathing, and circulation. So we may need to do resuscitation on these kids. They haven't been getting a lot of, they may not have gotten a lot of nutrients and oxygen because of the aging placenta, and they might be born depressed. So we would want to provide respiratory support because they've had some stressors. Just being born after 42 weeks is a stressor, so we'd want to initiate blood glucose monitoring, get those feedings started quickly. If they're hypoglycemic, we may need to transfer them into the NICU and give them dextrose. Moving on to some fetal or neonatal anomalies. I teach this one because Mrs. Wansey doesn't teach this in pediatrics. She teaches about other newborn anomalies. So I found a really good graphic to put on this slide, and this just shows the normal anatomy of the GI tract and the respiratory tree. And an esophageal atresia just means that it's a blind pouch. It doesn't connect to the stomach. So these kids, they are hungry, but they're not going to be able to eat anything. You could feed them, but as soon as it hits the bottom of that blind pouch, it's going to come back up. These kids are also going to be really drooly because where does saliva go? Where is it supposed to go? They could also have like frothing and lots of mucus because all of those secretions that should be going down into the stomach, they go down to the blind pouch and then they come back up again. You might feed these kids and then they'll throw up and they're going to be continually hungry because their bellies can't get full. So that's the big thing with esophageal atresia. With tracheoesophageal fistula, a fistula is an abnormal opening between two different parts of the body. So the rest, you can see that most of the rest of those graphics on the right-hand side show an abnormal opening either between the esophagus and the trachea, or from the top or from the bottom. Sorry about that. So if you feed these kids, they're going to aspirate down into their bronchial tree. And they're going to choke, they're going to sputter, they're going to cough, they'll turn blue. So if you have a child, a newborn, that is doing this, you need to stop feeding them and notify the provider, because these kids need surgery to be able to correct those defects. Okay, so nursing management, NPO, you want to elevate the head, provide hydration, so this kiddo will need some kind of an IV line. You'll have oxygen and suction available close by. You may need to provide respiratory support, especially if this kiddo has aspirated. What I did want to mention on the previous slide, many times during the 20-week anatomy ultrasound, the ultrasound tech will identify this kind of a defect and let the provider know, so that when the baby's born, the baby's already in that tertiary care center and have access to the surgeon that could correct the defect. But ultrasounds aren't 100% reliable, and you might be the nurse that has to identify and advocate for your baby. So the nursing management, you can see that respiratory support, comfort measures. These babies are hungry, they're NPO, they don't understand, and we need to give the parent education. So if this is a new diagnosis and they're not prepared for it, let's think about parents that are getting ready to have a baby. They have, in their mind, they have what the perfect baby is going to be. And when a baby is born that doesn't fit that mold, parents can go through grieving. Even perfectly healthy babies that may need to go to the NICU for whatever reason, for observation, parents can go through that grieving process. So we need to provide education as well as emotional support for parents during this time. After these babies have surgery to correct the defect, we'll be providing total parenteral nutrition, TPN, and that's through a central line until they're able to take PO nutrition. Providing antibiotics to prevent infection. These kids also will probably need some anti-reflux meds and antacids, and then lots and lots of parental teaching, because they're the ones that are going to take these kids home and have to care for them at home. So moving on to newborn infection. Also called neonatal sepsis, and it could be any number of a variety of organisms. So you can read through the risk factors on the left-hand side of the slide, and we'll be doing TORCH when we talk about antenatal care. So if the mommy has any of those TORCH infections, it puts the baby at risk for newborn infection. Assessment findings for a baby with sepsis. Oddly enough, babies that have sepsis usually are hypothermic rather than hyperthermic. It's just one of those things. If you find a baby that's hypothermic and you do your interventions and they just don't seem to warm up, that's really where your brain should go. It's like, ooh, I wonder if this baby has an infection. I need to call the provider. So also look at it, drainage, poor feeding, hypotonia, or poor muscle tone. If you don't feel good, you're just laying around and you don't want to eat, you don't want to be, moving around. So think about that when you look at these kids. They might have vomiting and diarrhea, abdominal distension, hypoglycemia because it's a stressor. They could also be in respiratory distress as a result of this infection. Their vital signs might be unstable, low oxygen saturation, and even possibly seizures. So once you alert the provider about your findings, they'll probably order a complete blood count with a white count differential, CBC with diff. They will probably also order a C-reactive protein, or a CRP. It's an inflammatory marker. They may order blood cultures, urine cultures, and yes, we can straight cath babies. And they also may want to culture the cerebrospinal fluid, CSF. And they do this by performing a lumbar puncture. So that would be the provider that does that, not the nurse. The other lab that they may order is a basic metabolic panel, or a BMP, that's electrolytes. For nursing management, we definitely want to keep a close eye on their vital signs, their I&O, and we want to monitor their weight, just like we would a normal newborn. We want to report and correct any fluid and electrolyte imbalances, administer antibiotic therapy, and provide circulatory, respiratory, nutrition, and developmental support. All the while, we should be providing education for the parents. Once the baby goes home, we want to make sure that the parent also recognizes if the baby's getting sick again. So not just what we're doing and how to care for their baby, but giving them good education about recognizing a potential infection in the future. Okay, a little bit about birth trauma. So we mentioned birth trauma in an earlier slide. You can read the risk factors on the left-hand side of the slide. And those bigger babies are the ones that are most at risk for birth trauma. I should back up a little bit. Looking at the second bullet point on the left, macrosomia, big body, big baby, LGA. If the baby's not presenting in a normal presentation like vertex, If a baby's presenting breech, they have a higher risk for birth trauma, or if they're a oblique or a transverse lie, also at risk for birth trauma. A prolonged labor or a really quick labor. You might have already seen babies in the nursery that have, the nurses might call it pressure face. Their face is bruised because of the rapid descent from a precipitous labor. The next bullet point is oligo, short for oligohydramnios. Oligo means a little of, and hydramnios would be amniotic fluid. So babies that don't have a lot of amniotic fluid are at high risk. CPD is cephalopelvic disproportion, and that just is what it sounds like. Cephalo is head, pelvic is pelvis, and disproportion. The baby's head is not fitting through the mom's pelvis. So these kids could be at risk for a fractured clavicle. That's why we want to make sure we do a good assessment on both clavicles after a vaginal or a cesarean delivery. You just don't know. And it's not just limited to large for gestational age babies. Some normal or AGA, average for gestational, and small for gestational age babies can have fractured clavicles. The first clue when you're assessing your baby, before you touch your baby, you'd want to just observe that baby and see what their range of motion and muscle tone is for all of their extremities. Babies that have a fractured clavicle often are holding their arm at in an odd position, and their range of motion is limited because it hurts. I'm going to jump down to the last bullet point, plexus injuries. That's a nerve, a bunch of nerves in the neck, and if those nerves get stretched too much, that could lead to a plexus injury, and you would also see an abnormal range of motion or abnormal positioning of that extremity. Then you would proceed to palpate the fracture or the clavicles to determine whether they have any defects there. And if there are none, then you would want to report that to the provider as a possible plexus injury. Moving back up, skull fractures happen, usually not as a result of a delivery, but baby falls happen. Parents and providers and healthcare workers can drop babies, and skull fractures can happen. Caput, we talked about caput in our normal newborn lecture, and cephalohematoma, both really are birth traumas. Lacerations can happen. I've seen several happen in my career as a result of C-section, whether it's on their cheek or their buttocks. The surgeon inadvertently just uses the scalpel and goes a little bit too deep. You might also see lacerations on the top of the head as a result of ruptured membranes. You might see like a little bit of a puncture wound as a result of the fetal scalp electrode. But you should be doing a good skin survey for any of these types of traumas. So if you had a fractured clavicle, you would probably be irritable and be fussy. If there's a skull fracture, the baby might have seizures. You might see flaccid muscle tone, abnormal range of motion I already mentioned, and discoloration like bruising. You will want to do a good head to toe assessment and then document very well, take vital signs, and then just monitor for bonding. So these kids have something abnormal, and the parent might not bond as well with that baby. So give good support, emotional support, education. Realistically appraise the situation and teach the parent that, and you may need to refer the child for community follow through. So for an example, not related to birth trauma, but those babies that are born with cleft lip or palate, you would want to refer them to the cleft lip and palate clinic at Children's Hospital. Hyperbilirubinemia. That means too much bilirubin in the blood. And bilirubin is a natural byproduct of broken down red blood cells. If you remember back to our newborn lecture, babies, when they're developing inside the mom, they have a higher red blood cell count and higher hematocrit than adults do. And that's because they develop in a hypoxic environment and they need more red blood cells to carry more oxygen for appropriate development. So after the baby's born, though, and they're getting oxygen from their lungs, they don't need quite so many red blood cells, so the body starts to break them down. Their liver is a bit immature and can't handle all of that extra breakdown products, and that's why they get yellow. They have hyperbilirubinemia, and we notice this with jaundice on the baby's skin. So some of the risk factors on the left-hand side are ABO incompatibility or RH incompatibility, prematurity, and if a baby has an ecchymosis, like a cephalohematoma or pressure face or any other types of bruising, that would also place them at risk for hyperbilirubinemia. So babies, after the blood cells start to break down, the body needs to excrete that bilirubin, that extra bilirubin, through the either through the urinary system or through the GI tract. So we really need these kids to eat. We need to provide nutrition because the fluid in the milk or the formula is going to help excrete through the kidneys and also through the GI tract. Usually, more commonly, those breastfed babies are at higher risk because there's not quite as much fluid being produced early on. We want to give some good teaching to the mother and the parents to watch for jaundice. The second type of jaundice is pathologic jaundice, and that's usually due to an ABO-RH incompatibility, and it manifests within the first 24 hours of life. Believe it or not, a really, really high bilirubin can cause an encephalopathy and a condition called kernicterus that is permanent. When the bilirubin is too high for too long, these babies can develop this condition, kernicterus, and it results in profound neuromuscular delays. These kids are never normal. So our assessment findings are yellow skin. Your transcutaneous bilimeter is going to show a higher level. Up in the right-hand corner, you'll see the nomogram. I hope you've seen that in clinical. And you would plot out the number that you see on the transcutaneous bilimeter. You plot that on the y-axis, the vertical axis, and the horizontal axis is the age of the baby in hours. There are usually standing orders on nursing units when it's above the yellow line or the red line to get a serum bilirubin. So the lab would come and do a heel stick and collect blood and run it for bilirubin. Once those results come back, you would plot them against another nomogram and let the provider know what that result was. Babies that have hyperbilirubinemia are usually lethargic. They may have temperature instability, and because they're lethargic, they're poor feeders. And that's exactly what we want them to do, so they excrete the bilirubin through the GI tract and the urinary system. That last bullet point on the left-hand side of the screen is a link to a Billy tool. And sometimes these Billy tools are used instead of the nomograms, and sometimes they're embedded into the EMR. So you may or may not see that used on the clinical units. So for nursing care, we'd want to do some really good assessment. We'd also want to do phototherapy if it's ordered by the provider. So the ultraviolet light and the blue lights that you probably saw in the clinical unit already, that actually helps that bilirubin break down so it's more easily excreted. You might see Billy blankets, and that's, we would put this fiber optic little pad on the baby's skin, and then we can wrap the baby up and hand the baby to the mom. And that light should stay on the baby's skin until it's ordered to be discontinued. You may also see babies in isolettes with bank lights, and we want to make sure that we have them pretty naked, except for their diaper, because we want all of that light to be hitting their skin to help break down that bilirubin. The other thing that we really have to consider is the damage to the eyes that this light could cause. So whenever you have a baby in phototherapy, you need to provide eye protection. Definitely some feeding support. We want to get this bilirubin moving out of the skin and into the GI tract and the urinary system. So providing some education to the parents for feeding. Again, bonding, parent education, and that last bullet point, exchange transfusions, very, very rarely done, and we're not going to test on that. Necrotizing enterocolitis, and I mentioned this earlier in the slide deck as a possible complication of the preterm newborn. So this is caused by bowel ischemia, which is the bowel isn't perfusing in one area, leading to some poor perfusion. Bacterial flora can overgrow. There could be perforation of the bowel as well as sepsis. This is a serious complication. So we'd want to look for risk factors like prematurity. That's the most common one. And we'd also want to look for signs and symptoms during our nursing assessment. You will probably see abdominal distension and pain when you handle these babies, or they're going to guard their bellies because they hurt. If you see abdominal distension, you'll want to measure an abdominal girth and then do serial girth measurements with every assessment. These kids could have bloody stools. They're probably going to throw up, like regurgitate entire feedings, and you might even see bilious vomiting, which is greenish. It's bile in that emesis. They don't feel good, so they're going to be lethargic. They may be apneic and go into shock. That last bullet point is a KUB, a kidneys, ureter, and bladder. It's an X-ray, and when they get the X-ray results, they'll see free air in the abdomen or dilated bowel loops. That's how they diagnose it. So again, predisposing factors for NEC are on the left-hand side. Postnatal are on the right-hand side. And that's just for your information. Nursing management, we'd want to maintain their fluid and nutritional status. So these kids need to be NPO and placed on bowel rest. They're also placed on antibiotic therapy and given IV fluids, sometimes TPN, total parenteral nutrition. Sometimes these can resolve with those conservative measures. Other times these babies need surgery to remove the dead portion of bowel and then re-anastomose the healthy ends of the bowel. Supportive care and then family education. And these are just some pictures of some other congenital anomalies. I especially want to point out the insides that are on the outside. So in the upper right hand corner is a meningocele or a myelomeningocele, also known as spina bifida. We would want to make sure that we do not position these kids on their backs because we want to preserve that sac. That's the most important care for these kids, is preserve that sac. If you see innards on the outside of the body, make sure you get some sterile gauze and some sterile saline and keep the sac moist and covered with saline gauze. I'm going to move on. The next anomaly that I want to talk about is diaphragmatic hernia, and that's an abnormal opening where the esophagus comes up from the abdomen into the thorax. Abdominal contents can herniate up through that opening, and that's called a diaphragmatic hernia. This would happen in utero. Sometimes the anatomy scan will catch this, so we know about it. When the baby's born, you're going to see a scaphoid abdomen or a sunken abdomen. These kids are probably going to have respiratory distress because one of their lungs is compressed with abdominal contents. What's really important with these kids is that we do not ventilate them with a bag and mask. They need to be tubed with an endotracheal tube and ventilated with the bag on the ET tube. We don't want to force extra air down into the esophagus and into the stomach. That'll just make things worse. These kids require surgery. In very severe cases, there's so much abdominal contents up in the thorax that the lungs can't develop properly, and that would be incompatible with life. These are innards that are outside. Omphalocele is when there's umbilical ring defect, so there's evisceration, or the abdominal contents are in an external sac around the umbilicus. A gastroschisis is the herniation of other abdominal contents through another abdominal wall defect. So again, keep the sac moist and intact. Imperforate anus is when there's no natural opening from the bowel to the outside of the body. So the most important thing about these kids, that's why we keep a good eye on when these kids first stool. So we want to make sure that we notify the provider if there's been no passage of stool within 24 hours of delivery. These kids need surgery, and they would be transported to a tertiary care center that could do this. And then we would have to provide that emotional support and teaching to the parents and get transfer ready. Bladder exstrosophy, that is also when an innard is outside the body. So this is when the bladder would be on the outside of the body. And the last slide in this deck is just dealing with perinatal loss. We talked a little bit about grieving that perfect baby, but we have to also recognize that some babies are stillborn, and other babies are born and don't survive. So perinatal loss has to do with any pregnancy loss or a neonatal death up to the baby's age of 1 month. It's a terrible experience. I personally have not lived through this experience. However, I've provided nursing care to many families that had to deal with this. We need to communicate empathy. These families, not just the mom, but the whole family is grieving the loss of this newborn. So providing them with lots and lots of tender, loving care. They don't need as much physical care as emotional care. And truly, in my experience, these are some of the most rewarding days in my career, knowing that the care that I was able to provide these families really meant something. So I apologize for ending on a down note, but it is part of nursing care. I hope you understood the contents of all of these slides. If not, contact me and I'll try to clear some things up.